Good afternoon. I'm here on the third day of the Best of SOHO. I have two guests with me who sparred each other. They are friends, and still they are friends. I'd like to introduce Dr. Zonder from Detroit, Michigan, who's a professor of medicine and oncology at the Karmanos Cancer Institute. And sitting next to me is Dr. Ravi Vij, who is a professor from the Washington University at St. Louis. Welcome, gentlemen.
Thank you for the invitation.
So before you start getting your hands on each other, I just wanted to set the stage. So you had a very nice presentation, both of you, on the big question in relapsed refractory multiple myeloma patients. So what is the scene with all these new drugs out there? What do you see in patients who eventually, with multiple myeloma, they get diagnosed and then they do relapse? What are the options, and what do you see in terms of the disease status?
So I think what the crux of our debate was optimal usage of these promising new therapies, right? So there are a lot of new treatments that have been approved, that are currently in development and about to be approved. We're going to have totally new classes of drugs like monoclonal antibodies. The question that we debated was using them together or using them sequentially, basically. Because I think we all agree that most patients see most drugs eventually. The question is when do they see them and in what combinations?
Excellent. And one of the questions that I want to ask you, Ravi, is in the relapsed refractory myeloma, you have the early relapses and the late relapses. So any distinction is that you didn't have that as a point of discussion, but
I think that's very true, that the early relapses, especially the first relapses, are often biochemical relapses. These are patients who are often working full-time and have got absolutely no symptoms, and you often will these days even work them up and do a PET scan, and you'll see that even the PET scan is fine. And in that patient population, it's often a dilemma that should you even intervene, much less should you go to 3 drugs instead of 2 drugs. And I think that population I find challenging, and they are the ones that I often will actually treat with 2 drugs, those are patients that I think you can follow closely, and you do really no harm by wait and watching those patients often and doing a serial step up before making a change to an alternative 2 or 3 drug regimen.
Excellent. So before we get to the actual the depth of the discussion, I should say that there was a ARS question, and the question was, would you do 2 drugs or 3 drugs? And the overwhelming majority answered 3 drugs, and you started off with that, and you were very happy. And what was your position at that time?
I think that certainly 3 drugs have honestly shown in multiple trials that you have better progression-free survival. And the issue is that literally none have shown an overall survival advantage. I genuinely believe it is getting more difficult to show that survival advantage unless you can control for post-transplant therapy. So we may at best have to contend with progression-free survival. But I also take the point that Jeff made, that you can use often these serially, and whether PFS2 would be a good surrogate. Now the issue is that PFS2 has been validated after frontline treatment initiation. To my knowledge, it hasn't been validated after relapse refractory therapy institution. So I think that PFS2, though I think is, agree with Jeff, a very good way to solve the dilemma of how to try to get over this fact that you are finding it difficult to show a survival advantage.
So before we get to the PFS2, could you, just for the purpose of the audience, could you define what the PFS is, the overall PFS and the PFS2 for clarification.
Sure. So PFS1 is from start of therapy to the point where your therapy stops working. PFS2 takes into account how you do not only with your first line therapy but also with your salvage. So it is from start of front line to end of second line therapy is PFS2, which is different than second PFS, which is just the PFS on the second line agent.
And if I could get to the replay of the debate, and your position that you took was PFS, right? So you quoted studies, you quoted the VTD versus TD, you quoted the bortezomib dex panobinostat versus bortezomib dex, the Aspire, the Eloquent. Could you just elaborate on that a little bit?
So I think that we now have the luxury of 4 or 5 trials that have looked at 3 drugs versus 2 in the relapse refractory setting, usually patients who have had 1 to 2 prior lines of therapy. They've all, as expected, shown that a depth of response is better with 3 drugs, which is fairly rational to expect. And they've all shown that PFS is better in terms of giving these drugs. Now, the question obviously that Jeff raised is the issue of cost and sequential therapy.
Could I stop you for a second? Before you get there, I think the PFS advantage was quite different. 9 months to 12 months, or 9 months to 14 months, or even 17 months, depending on the study you look at.
Correct. So I think that there are very robust differences in PFS when you add the third drug to the second. The question is, which is still unanswered, is if you gave every one of those patients who got 2 drugs the third drug at time of progression, could you make up for that?
So what is your take on that? You had you started with a 9%. Everybody not favoring your 2-drug approach, and you took heads on with the odds against you.
Yeah, well, I mean, I think that, so what I focused on was a little bit of just bringing this progression-free survival into perspective, that for many of the trials, the difference in progression-free survival is really more like 3 to 6 months, much more modest than some of the best studies. And there's no debate, though, that across the board, there's a consistent direction of benefit favoring the 3 drugs in terms of first progression-free survival, and also pretty consistently an improvement in quality of response. And as I sort of pointed out at the very end, sometimes getting that, response is so important. When you're talking about a patient like an early aggressive relapse that's not just biochemical, and somebody who's really deteriorating quickly, that third drug could be the difference between continued good health for some period versus having an irreversible complication of the myeloma or dying from the myeloma, never being able to get control of it. So, I mean, there are certainly circumstances where 3 drugs has to be your standard approach. But what I really spent most of the time focusing on, and I think that the audience really heard and I was encouraged by, and I think that listeners should be encouraged by, right? Because there's this perception that oncologists are not concerned about toxicity, are not concerned or oblivious to cost. And I think that those are the things that I focused on. And it's hard to put a dollar value on the kinds of improvements that we see with these triplets, but the difference in cost, particularly given the fact that some of the patients would be doing well even on doublets, it runs into the billions of dollars for the healthcare industry to just treat everybody with triplet therapy across the board. Most of these novel drugs cost in excess of $10,000 a month to give, and some of them are associated with real side effects. And we sometimes it's important to remind ourselves what, like a grade, as I did in the debate, what does grade 3 or 4 diarrhea mean? What does grade 3 or 4 fatigue really mean? I mean, functionally, those are significant side effects for patients. And, and if you're talking about a modest benefit in terms of progression-free survival, you may spend those few extra months really struggling because of the side effects of therapy.
I know it's a very friendly joust, but I think both of you do seem to agree on the same point. But at the point clearly about trying to balance the risk versus benefit, and how do you choose 2 versus 3 drugs? And going back to the earlier presentation that you had with the next generation sequencing, is it prime time yet?
Well, I think that next generation sequencing is something that we have to still do in the context of properly designed clinical trial. The information that we glean from it can be helpful, but the fact is that you do once again incur a lot of costs with very little often actionable information. Your insurance company will often not pay first for the test to be done. If you cross that hurdle, then you don't know the information you have received, whether that is in a founder clone or whether it is in a subclone that you have, and it depends on the depth of sequencing to get that information. Also, we are usually not getting what you call genomic DNA from patients. We're just doing somatic DNA, and so you often don't even know whether what you're picking up are possibly polymorphisms that patients were born with. So I think once you cross that barrier, okay, you're going to try a drug, you have a drug, then the next, who's going to pay for the drug? So that, I think, is a challenge that we have to somehow figure out how to do so. But I think the good beginnings have been made in that regard, with both the NCI and ASCO launching these basket and umbrella trials that the match trial of the NCI and the 2-part trial of the ASCO are going to, I think, try to at least start addressing some of these issues.
So we are not there yet. But going back to the one of the points that you made, PFS is a worthwhile goal. I think for many years we were debating what's the goal in a clinical study for relapsed refractory myeloma, and you said PFS is a worthwhile goal provided you have another salvage therapy.
The problem which you spoke on very elegantly is that with 3 or 4 or 5 or more lines of therapy available, it'll be very hard to ever prove a survival benefit from second-line therapy. So these trials that we discussed today, Endeavor, Eloquent 2, or the Aspire trial. We talked about all these really informative trials, but these are all in patients who are in their first 3 lines of therapy, basically. And what really happens to them long term is greatly affected by what they get later. So that's why, I agree with you. The PFS2 isn't validated for what it's worth in a second-line treatment, but I think it does stand to reason that we will need to continue to explore endpoints like that, right? Because we will never be able to design trials large enough to prove a survival difference. Certainly not a survival difference, maybe in some cases never prove a survival difference, and in other ones maybe only after follow-up that's so long that we've already moved on to other things before we even knew that answer. So we're going to have to, I think, accept surrogate markers for survival in these patients.
And I think that, again, PFS is an important endpoint, especially if you can show that the cost effectiveness issue that Jeff was trying to build up favors a longer period of disease control. We haven't yet reached that level of trial design wherein we can factor in cost effectiveness analysis, because yes, and believe me, I'm as passionate as Jeff is about healthcare dollars, but you also have to understand that your healthcare dollars potentially could be saving healthcare dollars by patients being in longer term disease control, having less hospitalization. So these are very difficult analyses to do, and these are analyses that may not be pertinent to all parts of the world. One set analysis for the same scenario in the United States may be totally different for cost effectiveness in Europe. So I think that we kind of definitely need to rein in costs, but the thing is we need to do it in a very meticulous way, that we take in not only the cost of the drug but also try to factor in healthcare costs that are saved by the
No, point well taken. I guess the Sagar Lonial's final presentation was how are we going to treat myeloma in 2020, at least his view of how we're going to treat in 2020. Looking further ahead, and you saw the PFS, we went from 6 months to 9 months to 12 months to 17 months to even as long as 20 months. So with all these new drugs there, what is the number that you'd like to see? At least ballpark number. We're making those increments in time.
I think we can agree we'd like to see that number be
as long as possible.
Long. We'd like to see some patients. I think we'd like to start seeing a plateau, is what we'd like to see. Where there are actually some patients who just live out their lives and don't relapse. Ideally, I think one of the things that Sagar was speaking to was, does MRD monitoring ever identify a patient population who could achieve that endpoint without the need for ongoing therapy? And because keeping disease suppressed forever on ongoing active therapy is not the same thing as curing them, right? It's giving them finite therapy a la lymphoma and being done with it. Right, so I think we have a ways to go, but for starters, if we could just reach the point where there was a significant number of patients who never relapsed, I think that would be a huge advance.
So, sorry, go ahead, Tom.
I was saying that what Jeff is saying is very true, that this has also come up as a point of a discussion with the elotuzumab RD versus RD study, where they're focusing on medians and trying to improve medians is the only thing we should be doing, because the immuno-oncology shape of the curve, I don't know whether that has been validated for the ELO-RevDex study yet. I think it requires longer follow-up, but there is at least an argument to be made that looking at those plateaus on the curve often means that you look at 1 year, 2 year, 3 or 4 year survival differences and look at the hazard ratio, and that the medians may sometimes not give you the full benefit of a drug.
Absolutely. So I guess beyond looking at median, the hazards ratio are also as important as the PFS. So I think I probably would want to end there with this discussions, and I want to say that both of them had very elegant points to make for 2 versus 3 drug, and even though you're friends and you still are, PFS and the big picture of PFS2 and the cost, I think the majority of the audience were quickly swayed, unlike a lot of the presidential debates.
Issue. I think these, particularly cost, but also side effects, they're hot button issues. The reality, though, is in practice, right? It isn't so clear cut about 3 drugs versus 2 drugs. I think we have a lot of patients that start on 2 drugs for the reasons that you mentioned, preference, still working, want to minimize the time commitment in the clinic, and a 3rd drug is added because the efficacy isn't there. And I think there are other patients who start with 3 drugs because the numbers are better, but side effects start occurring, or fatigue, sort of treatment, clinic time fatigue starts setting in, and we peel away a drug, right? And so in real practice, I think docs are following their, they're listening to that voice in their head, and they're also they're trying to do patient-centric approach to therapy. It's not just I treat all my patients with 3 drugs, or I treat all my patients with 2 drugs. I think there's actually a lot of individual variation in what patients get in any one practice.
I agree. We're doing personalized medicine of a different sort, and I think there is as much heterogeneity within a physician's practice as there is between physicians in this disease.
I was just going to say what you just said, Ravi, just personalized medicine to what the patient's needs are, and also keeping the macroeconomics in mind.
True.
Yeah. Thank you very much for this very lively discussion, Dr. Zonder,
Thank
Dr.
you.
Vij.
Thank you. Thank you very much.
Thank you.
Okay.